This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff from Thomas Jefferson University and the Neurology podcast. I'm here with Valtteri Kaasinen, a neurologist and researcher from the Neurocenter of Turku University Hospital in Finland. Val is the senior author on a paper published in the May 13, 2025 issue of Neurology titled Stability and Accuracy of a Diagnosis of Parkinson Disease Over 10 Years. In this cohort study, Val and colleagues examined a cohort of over 1,000 patients diagnosed with Parkinson's disease and examined the stability of that diagnosis, looking for rates of change in the given diagnosis. We wanted to bring Val to the podcast, discuss what he found with regards to our clinical ability to make a diagnosis of Parkinson's disease, but also explore how that diagnosis may be fluid or subject to revision as we monitor patients over time. Val, welcome to the podcast.
Thank you, Jeff. My pleasure to be here.
So let's start with key take-home messaging here. What did this study teach us about the stability of an initial diagnosis of Parkinson's disease?
The key message is that a Parkinson's diagnosis isn't always fixed. In our real-world cohort, which was diagnosed by neurologists, roughly 1 in 6 patients ended up with a different diagnosis. And this happened mostly within the first 2 years. So even after giving a PD diagnosis, we should keep an open mind and be ready to reassess.
As you said, 1 in 6, there may be a change in diagnosis. We have to be on the lookout for things that might change that diagnosis. And so when we talk about diagnosing Parkinson's disease, I'm hoping you can give us a little bit of background that predates this study. We think of Parkinson's as a clinical diagnosis. We talk about key clinical features, bradykinesia, rigidity, resting tremor, non-motor features, hyposmia, constipation, REM behavior disorder. And we use those clinical features to arrive at a diagnosis of Parkinson. We might use DAT-SPECT imaging to help with the diagnosis. And so as you set out to do this study, what did we already know about how well or perhaps how poorly neurologists are doing when it comes to using those clinical criteria to make a diagnosis of Parkinson's disease? And perhaps more importantly, making a diagnosis of Parkinson's that sticks with that patient over time.
So Parkinson's disease remains to be mainly a clinical diagnosis. We rely on motor features like bradykinesia and rigidity, supported by non-motor signs. And sometimes we also use dopamine transporter imaging if we are uncertain. From previous literature, we knew that in specialized centers who have access to neuropathological confirmation and are run by movement disorder specialists, they can reach up to 90% in accuracy of Parkinson's disease diagnosis. But that's under ideal conditions. In everyday neurology, with more variability in training, patient presentation, follow-up, this accuracy is often much lower. We also knew from smaller longitudinal studies that from clinical cohorts that diagnosis can change, but we didn't have a large, long-term, unselected, real-world data. And that's where this study comes in.
And so coming back to your study, and you've mentioned this is a real-world cohort of patients who received a diagnosis of Parkinson's disease. And so I'm hoping you can tell us about that cohort a little bit and what happened as you followed them. How did you follow them? How did you analyze these patients over time to examine that, the stability or instability of that initial diagnosis of Parkinson?
We first identified over 1,600 consecutive patients who were diagnosed with Parkinson's disease between 2006 and 2020. But then came the hard part. I personally went through the full hospital record of every single patient. This took me about 2 years, so that was honestly a bit of a crazy project. Unfortunately, I couldn't hand it off to a junior doctor or a computer algorithm, because this needed some clinical experience to understand the diagnostic reasoning of the treating neurologist. This was sometimes between the lines in the notes. After that, another movement disorder specialist cross-validated the diagnosis in a random subsample, and he was blind to my review. And we then tracked these diagnoses and diagnostic changes over a median of 10 years, collected dopamine transporter imaging results and pathology findings when those were available.
And just as a point of clarification, where did the cohort come from? This is from a registry in Finland, or this is records within your medical center? Where were you drawing this cohort from?
This was drawn from a hospital records from a southwestern part of Finland, 4 hospitals and all consecutive Parkinson's disease patients.
Perfect. And so now diving into this cohort, and you mentioned in our first question that 1 in 6 had a change in their diagnosis. And so if we start to look more closely at those in the cohort who did have that change, what was notable perhaps about those patients? Was the change prompted by additional clinical features that pulled them towards an alternative diagnosis? Was their testing completed that prompted a change? What can you tell us about the factors that perhaps may associate with a lower stability of PD diagnosis upon initial evaluation?
At the very beginning of the disease, when the motor symptoms were still mild and no levodopa trial had been done, actually we couldn't find any clear red flags that predicted future change. So the atypical features tended to appear maybe 1 or 2 years after the diagnosis of Parkinson's disease, and the big ones were poor levodopa response, vertical gaze palsy, prominent dysautonomia, or rapid progression. And one important factor here was the dopamine transporter imaging. So a normal dopamine transporter imaging prompted a very rapid change in the diagnosis. So normal DAT scan resulted soon to another diagnosis, most commonly essential tremor.
So I understand that, and that's really important to summarize that. Before that levodopa trial, at the initial clinical presentation, in many instances, there were not documented clear red flags that predicted subsequent change in diagnosis, but instead, over time, as you mentioned, key clinical changes, prominent dysautonomia, poor levodopa response, supranuclear gaze palsy findings, the rapidity of progression, those were the types of things that prompted a change in diagnosis, or as you said, using functional DAT SPECT imaging. And if that came back normal, then that also resulted in a pretty prompt change to an alternative diagnosis, most commonly essential tremor. Do I have that correct?
Yes, absolutely. So the key factor is the follow-up. So we need to stay alert.
Yeah, that's a great lesson to take out of that finding. And so in the study, you're following patients over time. You're looking at the stability of the diagnosis. So there's these instances where the diagnosis changed. Did your analysis look at whether these diagnoses were accurate? Maybe that's an important distinction where changing the diagnosis, we would hope, is towards one that is more correct or accurate. But for patients who had their diagnosis changed away from Parkinson's disease, does that bear out that the new diagnosis is maybe more certain or more clear, or did this study not necessarily get into that as much?
The answer is yes and no. So in many cases, we saw that the diagnosis became clearer, such as in cases with PSP or MSA. We checked the diagnosis against current specific diagnostic criteria of these diseases. So in those cases and in some other Parkinsonian syndromes, the changes were likely accurate. But here's the key point. In about 5% of all patients, the changes went into the category that we named clinically uncertain Parkinsonian syndrome. So even after a long follow-up and a full workup, the clinician was unable to come up with a specific diagnosis of a Parkinsonian syndrome. That's an important point. So that's a real-world scenario. It's not limited to general neurologists. So this has also been demonstrated in highly specialized centers with expert movement disorder specialists that around 5% of Parkinsonism cases remain undiagnosed before death.
that's a really important lesson to draw out. That one, we can use the diagnostic criteria that have been published and established, but recognizing that when this diagnosis is changing, as you said, 1 in 20 are being changed towards a diagnosis that is lacking certainty. And those of us who see patients with Parkinson's do recognize that it can be humbling, and there needs to be a comfort perhaps in some ambiguity at times that we may not be able to fully apply a checklist of criteria and say this is clinically definite or even clinically probable PSP, MSA, Parkinson disease. But Parkinsonism NOS is something that I know in my practice I've grown comfortable using when not all the checklists can be met.
Absolutely. It is humbling, but it's the reality.
And so when you look at those changes and when that initial diagnosis of PD is changed, can you talk a little bit about beyond the clinically uncertain diagnosis, what were those new revised diagnoses given? Is there any insight or commentary on which diagnoses do tend to emerge out of this cohort, or is it pretty broad?
Well, apart from clinically uncertain cases, the most common change diagnoses were vascular Parkinsonism, PSP, MSA, DLB, and essential tremor. Vascular Parkinsonism often came up when the patient had lower body Parkinsonism, poor levodopa response, and vascular lesions in an MRI. PSP, MSA were suspected when the patients experienced new features like gaze palsy or postural instability, orthostatic hypotension maybe, and if the disease progressed quickly. But in many cases, they were quite straightforward. For us clinicians, even with these uncertainties, we should remember that if a bird looks like a duck and walks like a duck, then it's probably a duck.
As we've mentioned, you follow patients over time, clinical features develop, and what looked like Parkinson disease, as you said, if you start to identify those cardinal features of these alternative diagnoses, the supranuclear gaze palsies, the profound dysautonomias, then that understandably takes us in a new direction. We've talked a little bit already about dopamine transporter imaging and SPECT imaging. And I did do a podcast back in August of 2024 with Eduardo de Pablo Fernandez about the utility of DAT imaging across the clinical Parkinsonian spectrum. And so, Val, looking in this cohort and looking at diagnostic stability or instability, can you talk a little bit more about the use or role of DAT SPECT imaging when it comes to the stability of a Parkinson diagnosis?
So in our cohort, about 1/3 of patients had DAT imaging, which it's a large proportion, clearly influenced decision making. Those whose diagnosis changed were more likely to have been scanned, so that is clear. And then, as I mentioned, a normal scan often led to a quick change in diagnosis. But I think it's important for us to remember that an abnormal scan is not specific for Parkinson's disease. It only shows the reduction in striatal dopamine function. So in my opinion, that imaging, it's a useful adjunct, but has limitations. Just it's costly. There's radiation involved. And most importantly, if we think of the global landscape of Parkinson's disease diagnostics, it's unevenly available. So there are regions such as Africa, even Australia, they just do not have that imaging. So even if we imagine that it's a perfect tool, which it is not, but just for the argument's sake, I don't think that imaging can never be the sort of a grand solution of Parkinson's disease diagnostic problems. So what we really need is a widely available, affordable biomarker, and hopefully we'll have that someday.
Those are all great points. And that last point, that DAT scan is not available everywhere and it's not a perfect test. And we need tests that are more accessible on a broader scale. But important to note that, as you said, if the DAT scan is normal, then that does clearly point us towards an alternate diagnosis that does not have that striatal loss of dopamine innervation. But when the DAT is abnormal, showing that striatal loss, that doesn't give us much discriminatory value, and the eventual diagnosis may still be subject to change to a PSP or a multiple system atrophy or one of these other dopaminergic degenerative Parkinsonian syndromes.
Exactly. But if we look at the current clinical diagnostic criteria, MDS diagnostic criteria for Parkinson's disease, a normal DAT scan, that's an exclusion criteria. So in that sense, it does have value in the diagnostics. A normal DAT scan patient using the current criteria cannot have Parkinson's disease.
So as we conclude, I want to shift over to perhaps some practical advice, and hopefully we've tried to be practical here too. And you've already alluded to the fact that across the globe, the access to certain testing or even the presence or availability of a quote unquote movement disorder specialist can vary quite a bit. And the presence or lack of formalized movement disorders training programs varies across the globe. And so inevitably, it's practicing neurologists and commonly who don't have additional movement disorders training who are encountering Parkinsonian patients and making diagnoses of Parkinson's disease. And so based on that phenomenon and this variability in different corners of the world, what do you think this study teaches clinicians about not only making a diagnosis of Parkinson's, but also how do we go about communicating that diagnosis to patients and their families? Should we hold off on being outwardly certain of a PD diagnosis when we meet patients because there is this 1 in 6 rate of change in the cohort that you studied? Or should we give them a PD diagnosis, but tell them there's evidence that the stability of that diagnosis is not 100% and may change over time? How do you advise clinicians seeing Parkinsonian patients to have those initial conversations about what patients and families can expect?
If you think it's Parkinson's disease, give the diagnosis, because that's the basis for treatment and planning. But it should be presented as your best working diagnosis today. So what I tell my patients is that in most cases, the diagnosis will stay the same, but in a minority, it may change as time goes on. And I think that we need to be honest, and this honesty builds trust and makes follow-up a natural part of care.
Those are all good lessons. And I know I talk with my own trainees that taking the time to talk to the patient, to hear about the history of their symptoms, to do the careful neurologic and movement disorders examination, it builds that trust. It helps them trust that when you do give them that diagnosis, they know you've taken your time to consider all of those clinical factors, but then taking that honesty one step further and say, today, the most probable diagnosis is Parkinson's disease. Here's how we're going to approach it. And to have that humility and say, there is a minority of patients where this may change and we'll follow along together and we'll take what comes and we'll pivot when we need to. If I'm hearing you correctly, it sounds like that's the approach that we should keep in mind.
Exactly. I completely agree.
Val, thank you. This has been really helpful. And so again, I've been speaking with Valtteri Kaasinen from Turku University Hospital in Finland, who is the senior author on a paper published in Neurology in the May 2025 issue titled Stability and Accuracy of a Diagnosis of Parkinson's Disease Over 10 Years. Val, thanks for your time and for your insights today.
Thank you so much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.